Good morning, everyone. I'm Emily. I'm the clinical pharmacist at Hospice West Auckland. Welcome to our webinar on deprescribing, part 2. Just a disclaimer that I have a cold, so if I have to stop and cough or blow my nose, I apologise. I'm unsure if any of you attended our previous pharmacist Beamer's presentation on deprescribing about a year ago, but I thought for this webinar we would go through some real-life cases of some of our hospice patients and examine some of the deprescribing tools that we have available. On the panel this morning, we have Dr. Oleg and Kylie, one of our specialist palliative care nurses. They will both be contributing to the discussion around the patient cases, and it'll be available to help answer any questions that you guys might have at the end of the webinar. If you would like to ask a question, just post it in the Q&A function on your kind of Zoom toolbar, and we'll answer those questions at the end of the presentation. If there's not enough time at the end, we will send out an email with answers to the questions. So this morning, we're going to go through a brief introduction to deprescribing, discuss some of the deprescribing tools that are available, and then go through 3 separate patient cases. Then we'll have time for a bit of a panel discussion and questions at the end. So I'm sure most of you are at least familiar with the term deprescribing. It is a process of identifying and discontinuing potentially inappropriate medicines with an aim to minimize polypharmacy, which is basically the use of multiple medicines, and improve patient outcomes. In more broad terms, the aim of deprescribing is to minimize and reduce medication burden, which may involve decreasing doses, reducing the number of tablets, or condensing the number of administration times for medicines throughout the day. Some of the commonly listed triggers for deprescribing include polypharmacy, the term I mentioned just before. This can be split into appropriate or inappropriate polypharmacy. In case of inappropriate polypharmacy, the patient may be experiencing side effects or a prescribing cascade, and it is this area of polypharmacy that deprescribing is targeting. Other triggers might include increased falls or an onset of delirium or cognitive impairment. The final trigger I have listed is the most important one to consider in our hospice patients or any patients undergoing palliative care, as there will often be many points in a patient's journey which the treatment strategy or goals of care are addressed and altered. All right, so Willow, I'll just get you to bring up the first poll, please. Okay, so hopefully you can see the poll on your screen. Over the last month, how many patients have you recommended or performed deprescribing on? None, 1 or 2, 3 to 5, or more than 5? If you'd like to vote. Alrighty, so what have most of us said? The majority of us have said 1 or 2 patients. And then next was none or more than 5. Pretty good. Cool. Thanks for answering that one, guys. And if we could please pull up poll 2, Willow. So when considering deprescribing for your patients, do you use a tool to assist you to make decisions? Never, rarely, sometimes, or always. All right, so a bit of a mixed bag of those answers. So we've got basically even numbers in all four options. So that's pretty interesting to know. Okay, cool. So thank you for contributing to the polls. It's yeah, kind of good to know who we're talking to. If you've ever thought about this before, if you do it every day in your practice, and yeah, there's a lot of just deep prescribing tools out there. So it's good to see that some of you use them all the time and some of you just use a clinical judgment and don't use the tools at all. So I'm just going to go through some of the tools briefly. This is not an extensive list, which, as Oleg and I were discussing yesterday, is probably an indication that none of these tools are perfect. Because if we had a perfect great one, then everyone would use the same one. So this is just a sample of the tools available. As you can see, I'm not going through each one individually, but some of them are not actually freely available online, which is also interesting. And a few of them have been developed for overseas healthcare systems. There was one for, the Priscus is for German healthcare systems, so probably a lack of applicability to New Zealand patients. There are potential limitations to all the tools available for identifying inappropriate medicines in relation to their utility in deprescribing. For example, most tools lack consideration of dose, as well as renal function and other patient characteristics, and may have only been validated or tested in certain populations. Explicit tools that just generate a list of potentially inappropriate medicines don't take into account the individual patient situation. And as such, a significant proportion of medicines identified using these specific tools may actually be appropriate and not suitable for deprescribing, even though that might not be the case in our particular patients. Additionally, these tools generally do not provide guidance on what to do once we've identified a potentially inappropriate medicine, which is not super helpful. And they also don't discuss how to prioritize making the clinical decisions around how to deprescribe or which to deprescribe first. I'm not sure if any of you are aware of or have seen deprescribing.org, which is a Canadian website, is helpful, but obviously made for a Canadian audience. I've also found quite a few resources produced for the Australian healthcare system, which may be a bit more relevant for us here in New Zealand. But unfortunately, from what I can find, there's not an all-encompassing or go-to guide from any New Zealand organisation. I've listed a few resources that I found and used during this presentation at the end, and I'll mention it again, but we can send those out to you in an email if you think they'll be helpful. So from this, it is clear that there's lots of different tools available. However, not all may be directly applicable to your patient population, and all decisions still require some degree of clinical reasoning. Okay, so moving on to our first case. This is Mr. JS. He's a 76-year-old NZ European male with a primary diagnosis of metastatic left lung adenocarcinoma. He has a past medical history of an NSTEMI with PCI, dyslipidemia, hypertension, gout, type 2 diabetes, a previous Pseudomonas pyelonephritis, and he's an ex-smoker. He lives alone, he's independent, and he has 2 adult children who also live in Auckland. His current medication list at the time of review is on the left. I'll give you a second to just read through those. And then, Willow, can we please pull up the third poll? Apologies. If Mr. JS was your patient and we were considering deprescribing, which medicine would you consider the first to deprescribe? Empagliflozin, omeprazole, atorvastatin, or aspirin? Sweet. Okay, so probably what I was expecting the answer to be as well, which is that the majority of you chose atorvastatin. Is probably one of the, I guess, most obvious things that we deprescribe and stop first. Not many of you said empagliflozin or aspirin or omeprazole, really. So that was interesting. Thank you, guys. So, yay. Okay. So here are some of the indications, quite obviously broad, for some of Mr. JS's medicines. And from what I could find, he didn't have any recent documented reason for omeprazole. He had a gorge listed in like an old GP referral maybe a few years ago. There was also a very old documentation of possible urinary problems, but the exact reason for doxazosin was not 100% clear if he actually had diagnosed BPH. So, keeping that in mind, my recommendations to the patient's GP. So, aspirin, given it's somewhat beneficial for secondary prevention, there's also obviously an increased risk of bleeding, and depending on how the trajectory of his disease goes, this could be ceased at some point in the future. On investigation, it actually turned out that the empagliflozin was the cause of Mr. JS's diarrhea. He was using an extensive amount of loperamide. The empagliflozin ADR was identified in hospital, but then accidentally continued on the discharge summary. So that was an easy one to stop for him, which also means we could stop the loperamide. Atorvastatin is, in this case, prescribed for secondary prevention. However, obviously, there's always a risk of side effects with every medicine. And thinking of Mr. JS's kind of trajectory of his disease and how long he's likely to live for, there's probably not that much no real short-term benefit and not too much long-term benefit that he's getting from the atorvastatin. So hence why most of us chose that one, because it's a pretty easy one to stop. What is next? So Mr. JS, because of his disease, has been eating less over the last few months. And because of this, his most recent HbA1c was actually quite low. And when discussing with him, he doesn't check his sugars. There's also, there's evidence to suggest that less stringent HbA1c targets in this sort of population and aiming for monotherapy in treating type 2 diabetes to both lower the risk of hypoglycemia is important in older and especially palliative patients. On speaking to him, he was actually only taking his vildagliptin once daily instead of twice daily, so we reduced that to how that was prescribed. So his BP was borderline hypotensive, so reducing both the doses of candesartan and metoprolol could be considered, also to minimize the risk of orthostatic hypertension, given the fact that he's on an alpha blocker with doxazosin. If he is finding symptomatic relief from the doxazosin, then obviously we want to continue that. So to allow that to happen, decreasing both the candesartan and metoprolol would be helpful. He has not had a gout attack in over 10 years. So the allopurinol could also be looked at being ceased. He hadn't had a uric acid level in ages, so obviously checking that before would be helpful. And he didn't remember why he was on his omeprazole. It's obviously been there for many years, and there's lots of research around the long-term effects of PPIs. So possibly we could give him a trial off that. He's not on any aspirin anymore, not on any NSAIDs, and he's not taking any steroids. So a trial off that medicine and see how he goes would be recommended. I guess 2 caveats. One is that obviously we would probably not want to stop all these medicines at the same time straight away. We would want to make sure that both the patient and the primary prescriber are in agreement with the plan and are both happy to kind of monitor how Mr. JS is going in the next few months in terms of, say, his uric acid level, his GORD symptoms, his sugars, and also his blood pressure. Things like beta blockers need to be reduced slowly so there's not rebound hypertension. And the other thing is that basically everyone will have a bit of a different idea of to what medicines they would cease and why and in which order, which is one of the kind of key takeaways today, is that deprescribing is a fluid, ongoing process. And like lots of things in medicine, it's an art, not a science. All right. Oleg, I'm not sure if you wanted to add anything.
Yeah, thank you, Emily. And I guess, that's a really great summary, as well as an example of actually how complicated and tricky deprescribing actually can be, and the amount of effort and thought that needs to go into it. And I think, at least for me, I've just reflected upon the patient in our situation whilst you were going through the case. For me, it just goes to show how transformative a pharmacist has actually been to our practice. As these issues of polypharmacy don't really, register on my radar on a day-to-day basis. And in the past, we've really, well, me personally, I've relied upon either the patient or the pharmacist, the patient or the family bringing it up, in terms of, does dad really need to be on all these medicines? And usually by that time, when the patient or pharmacist brings it up, we've already missed the boat, and it's, deprescribing is long overdue. So we've been really lucky that, deprescribing is now a much greater part of our practice, and something that all our patients are screened for. And I think this case just simply demonstrates the potential benefit with rationalizing medications, because we do know polypharmacy in itself leads to adverse outcomes, hospitalization, and premature death. And I just went through very quickly and counted his pill burden, which is about 20 pills a day. That's a lot if you think about it. So yeah, thanks for bringing that case through. It really demonstrates and highlights a lot of those issues, Emily.
Thanks, Oleg. And sorry, I didn't introduce again my panelists here. So Oleg and Kylie, you can now see. And yeah, they'll both be having input on the next couple of cases. So thanks, guys. Alrighty. So I thought I would bring to attention, in case you guys haven't seen this before, because this was something that I found in my research and I actually found it quite helpful. So it's from an Australian resource done by Primary Health Tasmania. And so this is like a screenshot of the kind of front part of the page. And each of these guides is like a few pages long. So there's lots of different classes of medicine. There's like a benefit versus harm graph at the start, which I think you can see on the left here under the proton pump inhibitor page. There's lots of algorithms to guide decision making. You can see in the anti-hypoglycemic. There's also a discussion and presentation of the original evidence for the use of the medicine in the disease. There's also a discussion of the common side effects. You can see on the right-hand side under the nitrates. And each handout, there's factors to consider, so in favour and also against deprescribing, which is really interesting to kind of read both of those paragraphs together. And there's also information about discontinuation syndromes, which, as I briefly mentioned before, we obviously can't stop every medicine straight away. Some of them need to be weaned or titrated down, especially things for, say, mental health conditions and things like that. So yeah, that it's very helpful. Alrighty, so moving on to our second case. This is Mrs. J.A. She's a 90-year-old female. She has severe cardiomyopathy and heart failure. Her left ventricular ejection fraction is 25 to 30%. She has a history of ischemic heart disease. She's had an NSTEMI with a stent placed, and she also has unstable angina. She has COPD with an asthma overlap. She has rheumatoid arthritis, osteoarthritis, recurrent skin cancers, depression, a previous DVT, hypertension, and recently in March she was admitted to hospital with another NSTEMI, a lower respiratory tract infection, and because of this had an exacerbation of her heart failure. She currently lives at home with her daughter and mobilizes with a walking frame. She's never smoked and doesn't drink any alcohol. As you can see, because of her extensive past medical history, she has quite a large list of medicines. All right, so there's obviously quite a few things we could talk about in terms of her medicines here, but let's just say that she is a very sprightly 90-year-old, mainly independent, but she's just been discharged from hospital with another NSTEMI, a respiratory tract infection, and therefore related exacerbation of her heart failure. So her medicines were adjusted. Anything above the aspirin was new or changed this admission. So we increased her furosemide dose. They started her on amlodipine. They started her on DAPT post the NSTEMI, and her isosorbide mononitrate dose was increased. So in this context, given a rough estimate of her age and comorbidities, her risk of falls, do we think it's appropriate to commence her on DAPT post an NSTEMI? Should we review her blood pressure in the context of the increased dose of furosemide plus 3 agents that reduce her blood pressure and also isosorbide mononitrate? How much benefit symptomatically is she gaining from the prochlorperazine and the solifenacin, which obviously are giving quite a high possibility of cumulative side effects? And other things to consider is her breathlessness. Is she using her inhalers correctly? And is she getting any benefit from using the salbutamol? So with that picture in mind, could we think about reducing some of the more, what am I trying to say? Apologies. The sideline kind of medicines. So the multivitamin, seeing if the solifenacin is giving her any benefit or not. If it is, obviously continuing. The prochlorperazine, was that an old hangover from an indication we don't no longer know? She's probably been on omeprazole long term, so trialing off that. And obviously, as before, we could stop her statin. We could also look at decreasing perhaps her beta blocker and ARB, given the fact that the furosemide dose was increased, but also might be causing orthostatic hypertension in combination. So this is all well and good, but in actual fact, Mrs. JA came home from hospital and slowly deteriorated within the next 4 to 6 weeks and had an increase in falls. She is now basically 100% bedbound and reliant on someone for all of her cares. And her medicines are purely focused on symptom management. And most of her regular medicines have been stopped. And she's now receiving subcutaneous PRN medicines for symptom management. And this is exactly what's happened to her now. So I'm not sure why they continue the aspirin. Might be something we can discuss after. They continue the solifenacin, and she's obviously receiving benefit from it, and they continued her inhalers, and everything else is stopped. I think one of the big points or takeaway messages from this lady is, should we have looked at initiating the deprescribing earlier, or would you, as a healthcare professional, be happy with the trajectory of this patient? Kylie, did you have anything to add?
Thanks, Emily. So what I would say is that often we blindly just keep taking all the medications we've been taking for a long time, and sometimes we forget even why they're prescribed. And thinking in palliative care, our focus is on symptom management. And you're looking at all of those things. And I think we thought that maybe they could have kept frusemide going because that would potentially give her symptom benefit. So like Oleg said also, I used to often think, why are they taking all those pills? And then not really say anything until the patient indicated it was an issue. So that's my thinking around that. And it's just really changing our mindset. And sometimes when we raise the issue, people say, oh, can I stop some of these? So it's definitely food for thought.
Yeah, absolutely, Kylie. And I think, this is quite a typical sort of scenario where there's rapid and aggressive deprescribing towards the very end of life. And I'm just, pondering that and wonder often when patients go into hospital with a whole bag of medication, and then they come out of hospital with pretty much nothing because there has been, an aggressive deprescribing process occurring, and what they must think and feel about that, or potentially if family hadn't been involved directly in that process, what they think in terms of all these medicines having been stopped. What is the value of that? What is the implication of that? So, that's a bit worrying in itself as well, that they, have all these medications stopped because, if they hadn't been of that mind, then they may not appreciate the rationale for doing so, let alone subscribe to that rationale.
Yeah, definitely. Thank you, Oleg and Kylie, for your input. Yeah, reiterating what they said, it's sorry. Yeah, definitely. We discussed yesterday, it can be quite hard for a patient, say this lady's been on most of these medicines for the past 20 years, and all of a sudden someone comes along and wants to stop them all. And if she feels in herself that she's a healthy 90-year-old, then maybe she doesn't want to stop them because she thinks that that's heading towards kind of end of life. So yeah, also obviously gauging our patients' kind of acceptability for deprescribing is really important. Alrighty, so sorry, I just need to cough. Moving on to our third patient, Mr. HD. He is an 80-year-old male. He lives in a care facility. He receives hospital-level care, but he has independent mobility. His primary diagnosis is an esophageal squamous cell carcinoma. He's been treated with palliative radiation therapy, but there is nothing more that oncology, either radiation or medical, can do for him at the moment. His wife passed away about a year ago, which obviously he's quite devastated about, and he has no family or support around him. His past medical history includes severe aortic stenosis. He has moderate left ventricular impairment, type 2 diabetes with mild peripheral neuropathy, hypertension. He's had bilateral total hip joint replacements, a previous cholecystectomy, and he's an ex-smoker. So what was I going to say? Oh yeah, so it's also worth noting that he's actually illiterate, and from our involvement in him and hospice's involvement, he doesn't have much insight into his disease and the disease trajectory. So that's something to keep in mind as well. So his main issue at the moment is that he obviously has esophageal carcinoma. So he has esophageal obstruction, which means he has an inability to swallow lots of medicines and also lots of different kinds of food. He's had a couple of presentations to hospital with a food bolus, and his medicines are crushed and put into like a thickened puree or food for him to be able to take them. So this is the medicine list on the right-hand side, which is also quite long, we can see. So he's unable to swallow whole tablets, and given that he's not for any further treatment of the esophageal cancer, obviously the obstruction is not going to improve and will likely worsen in the future. So this makes this patient quite different to our other two. We view the medicines in a different light all of a sudden, as the route of administration has become a major problem. So which medicines could he potentially do without and not have to get the nurses to crush and swallow them? So we could check his sugars and his HbA1c. Assuming his oral intake is less than it was before, this has probably dropped since his diagnosis. It's important to minimize the risk of hypoglycemia, and therefore a sulfonylurea, which is a glycoside, should generally be the first to go, as they can cause hypoglycemia. Empagliflozin itself is a lot smaller of a tablet than metformin. However, there's obviously lots of risks around taking it on sick days, and therefore it should be continued with caution. So let's say we stop those two and continue metformin only. Looking through clinic letters, as it turns out, radiation oncology had written a recommendation when they were seeing Mr. HD to cease his atorvastatin and the vitamin D, given his prognosis. So let's do that. It's not surprising Mr. HD has nausea, given his cancer and the location of his tumour. However, ondansetron, especially given regularly, can be very constipating. We can also see that he has two regular laxatives charted at the moment, so this is probably a problem. So perhaps switching this with another first-line antiemetic, such as metoclopramide, will be more effective, and it can be changed to something else if in a few days this is not the case. So let's change that. So hopefully this means we can eliminate the need for two regular laxatives. And if we change the lactulose to Malaxol sachets, this can then be thickened to prevent aspiration. Alrighty, so given information on his blood pressure, we could make a decision regarding possibly stopping quinapril, given he has no history of cardiac events, only aortic stenosis. We could also cease the aspirin. All right. Finally, regular ibuprofen in someone of his age and medical history might be acceptable for a short course to treat an acute injury or acute event. However, given this is likely not the case, and unfortunately, given that he's in a rest home, this is something that might often be forgotten or left on the regular chart. It's probably best to focus just on the use of the regular paracetamol and the morphine liquid when he needs it. So basically, we are now left with the medicines that are just treating his current symptoms. I'll give you a second to have a look at the list. And we're also using medicines that are crushable, such as the short-release metoprolol and liquid forms, to hopefully reduce his tablet burden. Oleg, would you like to make a comment at this point?
Yeah, absolutely. So I guess, it was my ears perked up when he said he was illiterate and perhaps had a poor health understanding. And it just reminded me, in actual fact, in terms of medication adherence rates in the community, and potentially this patient may not have even been taking the vast majority of medicines prescribed, and that's something that I guess I see fairly commonly. Boxes and boxes, or bottles and bottles of medications stuffed into the cupboard. Prescriptions are, dispensed and picked up, but the majority of medicines aren't actually being taken anyway, simply because the patient doesn't know why the heck they're on them, and they see no value in them. And so I think, potentially these medicines are redundant with either we're aware or unaware. So just pruning these medicines off just simplifies it for them as well as us. I would like to extend that deprescribing a little bit further with the metformin. As you've rightly pointed out, Emily, we need to be aware of his type 2 diabetes and how it's tracking. But with his increasing debility and frailty, he's likely to be losing a lot of weight in condition, and that in itself will resolve a lot of his hyperglycemia risk. And from a palliative care perspective, we're fairly generous in terms of hyperglycemia, tracking anything up to 15 of a blood sugar is perfectly fine, at least in my eyes. The main thing we want to avoid is the potential hypoglycemia. So it's great you stop the glucoside in that regard. But the additional problem with metformin is it can actually continue to cause gastrointestinal side effects, and it is quite a big tablet as well. So I'd be worried about, I'd be mindful about the metformin. The other thing as well, the omeprazole, it's a very big dose of omeprazole, 40 milligrams BD. I suspect he probably doesn't need to be on that big a dose. Undoubtedly, he would have considerable dysphagia and potentially odynophagia, but a significant proportion of that wouldn't be directly related to acid secretion. And so, just keep continuously cranking up that omeprazole in terms of trying to alleviate his odynophagia. You're missing the boat pretty much. It only does a certain amount, and it doesn't do any more. So potentially he could have that omeprazole reduced back down to 20 BD, couldn't he? In addition, I would also challenge the metoclopramide and say, in actual fact, my first line is domperidone instead. So I would always use domperidone first line rather than metoclopramide.
Thanks, Oleg. Alrighty. So, as I mentioned before, these are the resources that I was using during making this presentation, but also ones that I just found interesting and helpful in terms of some articles to read and the Primary Health Tasmania at the top there that I showed you screenshots of before. So we can definitely send these resources out via an email if that would be helpful. And yeah, as I mentioned, there's not anything specific from a New Zealand point of view, unfortunately, that kind of covers everything. Alrighty. So moving on to the Q&A session. I think, Oleg, are you happy to run that, or would you like everyone to share a learning first? Oh, sorry, you're on mute still.
Yeah, let's go through the Q&A first,
Okay.
because we do have a few questions that have come up. So let's have a look. I'll just go through the first question. Do you have any pain tools in the elderly? I see a lot of CD prescriptions in the elderly. I think that's controlled drug prescriptions in the elderly. Thanks. So, Kylie, do you want to answer that? And
Yes, thanks, Oleg. So I don't know that we specifically use a tool. Well, I don't necessarily use a tool, but a pain tool. So there are lots of things we can ask about pain. There's lots of ways we can assess pain. And I don't use a formal tool, but I know lots of people do. And thinking about controlled drugs in the elderly, we use controlled drugs a lot in the elderly, keeping in mind always that that someone is frail. We need to be careful of falling, things like that. So with caution, we do use controlled drugs, and most of the time we don't have a problem. A lot of elderly are concerned about using morphine and things like that, and we can just explain how morphine works, and most of the time people are open to trying it, and we see that it's fairly well tolerated. I don't know if you'd agree, Oleg?
Yeah, absolutely. No, completely. And I guess, truth be told, Kylie, there are a plethora of pain tools available and validated. I guess, in answering that question from my perspective, it really depends upon what you're trying to achieve. So you need to match the tool to the need. Is it going to be a unimodal, such as quite simply the numeric rating scale from 0 to 10, or the faces, or is it going to be a multimodal, multidimensional tool? Also, is it going to be clinician administered, or is it something that a patient or family can administer? And finally, is it going to be a subjective tool, or is it going to be an objective tool in terms of subjective that relies upon the patient report, or objective relies upon the clinician observation, depending upon how reliable or able the patient's able to report because of communication difficulties such as dementia or aphasia, for example. So it really depends upon all those factors in terms of the utility of these tools. But also, I would say, depends upon the organizational factors as well. You can't use a tool yourself that others in your team are unfamiliar with or hasn't been introduced or endorsed by your organization, because you really do need to speak a common language. So, if you are wanting to introduce a tool into your team where everyone is familiar with, then that would be a process, an implementation process where you need to do due diligence, figure out which tool you want, why you want it, potentially even an audit of your current practice to identify the gaps, and then enroll the entire team, introduce the tool, and look at the impact. That would be perhaps the ideal approach. I know it's a lot of work, but if you're really wanting to make a difference, then that's probably what's required in terms of introducing a pain tool into your team. Hope that answers your question. Another question, how about patients on insulin with palliative care end of life, at palliative care end of life? Emily, do you want to give that one a go?
Yep, sure, thank you. Let me just think, just from my kind of readings, sorry, I've got a lozenge. I guess two things. Obviously, we want to, assume they're type 2 diabetic, because type 1 is a different ballpark. But if they're a type 2 but diabetic that has progressed to using insulin, a lot of the Deprescribing guidelines recommended continuing, say, like a bolus nighttime dose of insulin alone and stopping all the orals. Because obviously you therefore have kind of greater control over how much is given, and you can easily counteract any hypoglycemia and things like that. And yeah, obviously, like what I mentioned before, have we looked at the HbA1c? Is it almost too low? Should we be aiming for higher sugar targets? Are they the kind of person that checks their sugars? Do they have someone there who can help them? Are they in a care facility who does it for them anyway? But yeah, definitely the general recommendation is to actually stop all the orals and just continue on insulin alone.
Yeah, absolutely. And it's a matter of simplifying the insulin regime. So not really adhering to like a BD or TDS basal bolus regime, and just having a once daily dose of a long acting insulin. You really do need to, reflect upon what the actual goal of care is. In palliative care and end-of-life care, the goal really is for ensuring symptom management and quality of life, as opposed to guarding future well-being. And so, being relatively generous in terms of what's tolerable from a blood sugar perspective, in simplifying the regime and simplifying the monitoring, I think is the way to go. But sometimes, you do reach a bit of a hurdle. You do encounter a bit of a hurdle, especially if a person is also potentially exposed to a steroid burst. Can you comment on that, Emily?
The steroid burst?
Yeah. Well, if a person comes under palliative care, by and large, they always have
We
a
give them
burst of steroid
steroids,
before
yeah.
they die. So, yeah.
Oh, sorry, my lozenge. Yeah, I mean, obviously, we know that giving someone steroids increases their sugars. And yeah, obviously, in people who are, in active treatment and we at the start of their kind of disease progression, then that's something we definitely need to think about. And they'll often, say in oncology, see the diabetes nurse or like get counseled a lot on adjusting their insulin and stuff to that. But obviously, at the end of life, then the goal is obviously not the same at the start of their disease. So, giving them, say, 3 days or even 2 weeks of a steroid course, but adjusting their insulin to accommodate for that might actually mean that the insulin dose accidentally stays high when they finish the steroids, and then we might have hypo events. It's very dependent on how much the patient or the family is around and capable of monitoring and things like that. So it might almost be easier to just tolerate the hypoglycemia events we get with the steroids, just to continue the insulin at the same dose and make it simple.
And also being mindful that if a person has simply glucose intolerance before the steroid trial, then they're going to be at risk of experiencing symptomatic hyperglycemia. And I must admit, we've been caught out a couple of times in the past in that regard, where a person has had to be hospitalized because of hyperosmolar hyperglycemic syndrome. Great, thanks, Emily. We've got another question. Citalopram or escitalopram has huge side effect profile. How easy is it to deprescribe? So I can comment on that. Really depends upon the original indication for the antidepressant and how, and if the actual diagnosis of depression, the original diagnosis was robust. And so it requires a little bit of diligence in information gathering to see if you can disclose this information. How long have they been on this medication for? And was it truly depression to start off with, or were they just feeling a little bit sad and they were whacked onto it? In terms of deprescribing these antidepressant medication, it would be a process simply of stepping down pretty much at the same rate that these medicines are initiated in. So in terms of deprescribing these medicines, if there's no ongoing mood symptoms, and if the original diagnosis was a little bit vague or uncertain, and they've been on these medicines for years and years, then yes, absolutely, you could well stop these medicines. But it would need to be, done in a stepwise fashion. Any comments about that, either of Emily or Kylie?
Yeah, I agree with what you're saying, and we see a lot of people on citalopram or other antidepressants and have been for years, and they've been afraid to stop and they've just kept taking them. So it should be weaned down anyway, and you could just balance that with the effect, and it could be weaned down and stopped, couldn't it?
Yeah. Absolutely. Moving on, why was the elderly lady on salbutamol right to the end? It can make you feel anxious and jittery. And would she have bronchospasm? I feel like it is overused for breathlessness and can make the person feel worse. Interesting. That I can't help but agree at some level to that as well. Emily, what is the evidence?
Yeah, I definitely agree to that statement that we see some people who, are prescribed 2 to 6 puffs, how many times a day they want it. And then, it's not actually helping with their breathlessness anymore. And it is making them feel really agitated and jittery. Because they're just getting way too much.
Yeah. And it's not the right term for it, but they get a little bit, I guess, not addicted. They get a little bit, I guess, reliant upon the use of their inhalers because it almost becomes like an automatic behavior, doesn't it? Breathless, automatically reach the inhaler, and it's that placebo effect of actually engaging in action, which is of benefit. But in doing so, they end up taking like 20 inhalers a day, and that can definitely spill over to systemic side effects. So I absolutely agree with that person's comment. Salbutamol, beta-2 agonist should only ever really be used when there is proven bronchospasm, when there is a patient has underlying asthma or COPD / asthma hybrid. And in actual fact, a lot of the bronchodilators that's out there probably doesn't actually do anything. All right, moving on. We've only got time for one last question, perhaps. How about blood thinners like warfarin and dabigatran, rivaroxaban? Are they stopped when a person reaches palliative care? Either of you willing to take that one on?
I can say in regards to warfarin, I'm thinking about the blood tests that people have to have and the burden that creates. And so if I had a patient on warfarin, I would encourage that to be changed. And that's probably as much as I could say about that. But we do see patients continue on other blood thinners right until they're nearing end of life.
Emily?
Yeah, I would agree. It's there's definitely quite a lot of guidance about stopping, especially anticoagulants. But we have had a couple of patients who are on warfarin, and I know that's obviously quite a burden. Like if someone's housebound, how are they going to get their INR checked? And then if we can't check their INR, are they at risk of a bleed, like a catastrophic bleed in front of all their family and things like that? So it's definitely obviously personalized risk balance, but definitely something that should be considered as long as the patient and the family are aware of the risk of stroke and things like that if we stop the anticoagulant. Yeah.
And always focusing on what is the goal of care, what are we trying to achieve, and having that discussion with the person and figuring out the way forward when it's clear in terms of what the motivations are with the stakeholders. That's all the questions. Sorry, apologies if we haven't been able to answer the questions that you've posted. What we will do is we'll still collect them and send out the answers via email for the ones that we haven't been able to attend to during this webinar. But I'll hand the session back to Emily.
Thanks, Oleg. So just summing up, thank you everyone for your participation today. Thank you very much for thank you very much to Oleg and Kylie for your contribution as panelists and in the Q&A session there. And on the screen, hopefully we'll be able to share it in a second. We've got the Doctor's Direct line coming up. So you can call anytime during working hours to speak to a palliative care SMO if you have any questions about your patients and their palliative care needs. We'd also really appreciate it if you're able to complete the evaluation form, which will pop up after the webinar ends. That will provide us with some valuable feedback. And the details for the next webinar are up on the screen there as well. So thank you. Have a great day.